The collapse view opens up as a surgical sieve because that's the best way I think about thinking about collapse. I think it's probably better than thinking about it in a rank view because there's so many different types of reasons for collapse, or by anatomy where the collapse tends to get more uh, distributed towards the heart or the neurological causes, and therefore you've got too many diseases to show across the surgical sieve, and this being vitamin A, B, C, D, E, which is the most common surgical sieve that is used. See how the different presenting complaints, of which there are around 40 here, are quite evenly distributed, which allows you to actually look in detail at it and retaining the information. So up here, as I said, we've gone potentially we can move between rank, sieve, and anatomy. We can once again use our highlighting to say what are the high morbidity causes of collapse. As you can see, for 18 to 34-year-olds, the only real one, influenza, severe influenza, is the only one that is common. Is actually mostly uncommon causes, rare causes of those that are quite serious. Obviously, serious things are things, aortic problems, strokes, hematomas, sepsis, and meningitis, things like anaphylaxis, and then moving down ectopic pregnancy. And you've got some quite rare cardiological diseases, BFVT, HOC, and prolonged QT, don't often happen in 18 34 to 34-year-olds. So the way that you can work this through is you can start to say, well, let's look at the common ones. If you click on common, it does actually start to show you all those. You say, what are the uncommon causes or rare causes? But I tend to, when I'm looking at these, I tend to think about the common, and I tend to think about the important causes, the red ones. And that's something which often taught as well when you're in the emergency department. The other way thing is also looking at is you can chunk it off and say, what are the vascular causes? What are the idiopathic causes? What are the traumatic causes? And there'll be a highlight down each side as well. Now, for example, for collapse, one of the things you often say is, was there trauma or not? So if we say no to trauma, it actually removes most of, but not all, the traumatic causes. So one of the teaching points here is for collapse, a good history of trauma will rule out an extradural hematoma, but not necessarily a subdural. So lots of people, well, not lots, but some people can actually still get that. So that's why this is actually set up to allow that sort of level of thinking, is that if it would definitely rule it out, it removes it, but if not, it still can bring it into things. Number of red flags here, and so if someone, and let's pick a different age group here, 50 to 64-year-old, as you can see, suddenly there's a lot more common causes coming through, especially cardiovascular diseases causing collapse, alcohol and drug, peptic ulcers, atrial fibrillation. So by changing the age bracket, if we went just to 0 to 1-year-olds, there's going to be quite a fewer bunch of things, and also much more uncommon and rare. So naturally, is quite a bit of learning by actually looking at the cause of collapse by age bracket. And there's no no, shouldn't really use the all option here because there'll be duplication there. If we go back here and we say, if someone's collapsed and has shortness of breath, that's a red flag. So someone who's collapsed with shortness of breath could be having a myocardial infarct, sepsis, anaphylaxis, influenza, or the cardiological diseases we talked about before. If they've got neurology to find, well, actually, that makes us start to think about the cardiovascular accidents, cerebellar CVAs, subdural hematomas, potentially. So that little subscript next to it only occurs with the red flags, and it only occurs for the red or occasionally the orange diseases to really get you to start thinking about those. Once, as we answer more and more of these questions, recent procedure, no, it removes post-procedure and post-surgery. Any change to medications? No, they didn't have any, then medications aren't going to be causing this if there's been no real change. One of the key things here is if someone is febrile, it actually does change your differential quite a bit. So someone who's 65 years old who is febrile and had a collapse, you really have to look at these worrying causes here, and you'll be looking to do bloods and blood cultures and all those sorts of things. If we sort of went into, for example, bacterial meningitis here, it tells us, you've just got to put the mouse inside there, it just holds. Tells you about the inflammation there, triad of fever, headache, and neck stiffness, thinking about that. Symptoms you can find and sometimes find, so not often to get decreased level of consciousness, but can, same with a rash, same with seizures. And then just sort of some of the other bits here about how to, treat it, and empiric antibiotics is time sensitive for outcomes. And given antibiotics, someone is giving steroids, what you find on lumbar puncture here. Now, one of the important things also is that when you go to the referral speed, that actually highlights all those that have got a similar referral speed. So if we go down to the bottom here, we can actually reset whole view. That allows you to refreshen things. And if I go to cardiovascular disease accident, which we know will be managed by neurology, and I click on that, I can actually highlight all those that are neurological causes of collapse. What I can also do is push on keep only here, and therefore then suddenly we've actually got just those causes. So if you're doing collapse and you're on you see collapse and you're on neurology rotation, especially on the wards, these are the sorts of things you're thinking of that would be naturally looked at by someone in neurology or neurosurgery, as opposed to the other kind of causes of collapse, which the ED might have ruled out or might have sort of worked up into different specialties.